maybe 12 cells. And so it's a little bit harder to use some of our traditional genetic techniques in order to diagnose those types of epilepsy. And we're working through that. It's being done on a research basis right now, but most of your genes are going to be found in every cell of your body. You're going to hear me use the word variation, and this is where I always stop and kind of have to give an explanation. So you won't hear me use mutation throughout the day today. Variation, think of it as the politically neutral term, okay? All it means is it's disease causing, it doesn't mean it's rare, it's just a change. So one of those letters is change. So when everybody has an A, you might have a T, okay? So that's something that a lot of people, it's a shift in the terminology because a lot of people didn't like the word mutation. There's also other words that mean that a DNA variation is really common in the population, where like 60% of the people in this room would have it. Well, obviously that's probably not causing seizures, right? And so that's just a normal variation. We all have thousands and millions, actually, 3 to 4 million DNA variants, and that's why we're all different and unique, okay? So some of these variations are going to cause disease, and then some are going to be benign and just be part of what makes us us, okay? So with epilepsy, right now we know there's hundreds of genes that are associated with epilepsy. Some of these directly cause it, some of them indirectly are related. Some of them just cause epilepsy, some cause epilepsy plus other syndromes, okay, or other symptoms. What we know the best are the early epileptic encephalopathies. So these are the ones Dr. Siliberto mentioned that are really severe, and these kids are having lots and lots of seizures. And kind of with everything in life, we tend to get, we have a bell-shaped curve, and there's the more severe cases and the less severe. And with genetics and just biology and understanding disease in general, typically we start with the more severe, and that's the easier stuff for us to figure out in the lab, and then we can start applying the lessons we learn from that to the rest of the less mild or the less severe cases, in this case some of the other epilepsies. It's a rapidly changing field, so we're learning a lot about epilepsy, and on average there's 1 to 2 new genes described every month, which is crazy. I'm a geneticist and I do stuff with epilepsy, but I actually am involved with all types of genetic types of disease, and we don't see this rate with any other disease that I'm working on. So it's a really rapidly changing field, which is great. We're learning a lot more every month. And if you wanted to get the list of those genes, you can go on that Cure website, and they have some of them on there. When we're looking at genetic causes of epilepsy, we can do this a couple different ways. So one of the things we can do is look at a single gene. So Mike mentioned the gene SCNA1, and we can just go in and say, okay, well, we think Dr. Siliberto thinks that this is what's causing your symptoms, or your seizures, so we can just test that one single gene. And that's how we used to do this. And being used to, in genetics, things move really fast, so how we used to do things is as even far back as like 5 years ago, okay? So it's not that old. Most of this is pretty new. But we would do one gene at a time, and we would just go through, and Dr. Siliberto and I would work together and go through and pick one gene at a time. Then these things called gene panels came along, and this might be 10 genes to 200 genes that we would test at a given time, and that's because of a new technology which I'll mention later, but we can look at all of them. So it's cheaper and faster now to look at multiple genes rather than go one at a time. There are a few cases where your doctor may pick one gene, but in general they're going to look at these panels. Not all of those genes will be related to your specific type of epilepsy, but they will have representation of a lot of the epilepsies. The problem with those is, if you recall, I just said we have 1 to 2 new genes a month. I also co-direct a diagnostic lab, and we make gene panel tests. And when we do this, it takes about a year to make a new test. So when you have 1 to 2 new genes coming out a month, the minute your test is live and you can start using it, it's already out of date, right? Because you've had to go through all the validation steps. So just like Dr. Siliberto was saying with drugs, in the lab we have to do that as well to make sure our tests are working correctly and picking up the things that we want them to pick up. So the gene panels are great, but they're also not going to, you might have a gene panel that's negative, but it's not because your seizures are not genetic, it's just that the gene that's causing your seizures may not be on that panel. And we're seeing that really a lot more frequently now. So then there's two other ways we can do this: whole exome sequencing, which I'll talk to you about today, and whole genome sequencing. So whole genome sequencing is the easy one. We just sequence all the DNA in your body, okay? And we can shotgun through that. It's going to be more expensive. Right now, we're going to go back, and we can't analyze everything. We don't know what it all means. There's still a lot of research going on across all forms of disease, trying to figure out what do genes do, how are they working, what diseases are they causing, and things like that. So when we do this, we won't be able to interpret it all, but there's reasons we would do this, and we'll probably be launching this test within the next year here at the University of Iowa. And then, like I said, we'll talk about the exome in a minute. But the de novo mutations, I want to just talk about this for a second, because these are the most common DNA variants that we're seeing that are causing epilepsy in those early epileptic encephalopathies. And we see all different types of inheritance. So when I talk about inheritance, we're going to talk about DNA variants you get from your mom and your dad. So there's some types where you only need one DNA change or one DNA variant in order to get disease. There's others where you're going to need two, one from mom and one from dad. There's another type where you only need to get one from mom. Mom doesn't have to have the seizures because she has two X chromosomes, but her sons may have one, and I'll give you an example of that one later as well. And then de novo means spontaneous. So this just arose randomly in the egg or the sperm. We have no idea of we can't go back and figure it out. But neither parent has this DNA variant. It's unique to the child. And so this is what we're seeing more commonly. And this is really important to understand, because when we do this exome test in the genome and even some of the panels, in order for us to accurately interpret the results, it's really helpful to have those parents, okay? Without the parents, like I said, there's 3 to 4 million variants. It's really hard to narrow down which is the variant that's causing the seizures, okay? So de novo is a term I want to introduce just because it's one you'll hear about more with seizures. So the clinical whole exome sequencing test, some of you who were here last year would have heard about this from Tracy, but we'll go over it again. It's a tool. So in general, I think all genetics is a tool. It's not something that has to be limited to a geneticist. We'd like our neurologists to be able to use this, our cardiologists, any of our physicians. We want them to be able to use DNA testing as a tool to help them with their practice. And so this is another tool, just like every other genetic test, that can narrow that differential diagnosis for a patient with an undiagnosed condition. So what does that mean? So the differential diagnosis, you go to your doctor and you say, I have a headache. They go through the list of all the possible things that could cause your headache. That's your differential diagnosis. So for seizures, your differential diagnosis would be the different genes as well as the other things that could be causing seizures, right? Not all of them are going to be genetic causes. So this is a tool to kind of narrow that list down. We often use it in diagnostic odyssey patients. These are the patients who have had lots of different tests, not just genetic tests, but biochemical tests, muscle biopsies, different things, and they still have no answer for what's causing their seizures. So they've been on this odyssey trying to find an answer. We also often use it in patients with that really long list for their differential diagnosis. There's so many things on there, we're not sure where to start, so how do we narrow it down? Because not only can this test diagnose things, it can also rule out a lot of things that are going on to help your doctor figure it out. And then atypical presentation of disease. One of the things that as this testing has become more and more common, what we're seeing is things that we thought were disease A and disease B are actually getting blended, and there's more of a spectrum with a lot of types of diseases, not just seizures, but a lot of our neuromuscular diseases and others, where things we thought were separate categories we're realizing aren't necessarily. So sometimes it makes it hard for your healthcare providers to figure out what's going on because yours might be slightly different than what they would expect, and so they need to be able to see what other genes are involved. Real quick, I guess I skipped this one, symptom-guided analysis. So when you do this, if we're sequencing all the DNA in your body, we can not only find the cause of your seizures, but we could figure out if you were at risk for heart disease or cancer or Alzheimer's disease, any of these things, because it's all going to be in your DNA as well. So depending on which lab is doing the test, they may or may not use symptom-guided analysis, and that impacts what type of results you're going to get back. So most of our patients here at Iowa, and our physicians as well, said, okay, we're using this test as a tool to help diagnose epilepsy. the parents or the patients, the physicians, they might not want to know about your risk for colon cancer. I'm guessing Dr. Siliberto doesn't want to be talking to you about your risk for colon cancer. Like he said, he likes the brain, right? So this is something that our physicians, in order to make it a useful tool, we really listen to the physicians as well as the patients. Other places will mandate that you get back your risk of colon cancer. Now, if you have a newborn baby who's in the NICU, this might not be the best time. You're just trying to figure out what's going on. And so for us, we do symptom guided, but that's different everywhere. And if you have this test, you need to be asking about that and just learning what you want to know and what you don't want to know, okay? That's always going to be your choice. So symptom guided analysis means epilepsy. We actually have over 800 genes that automatically get put into the pipeline when we hear epilepsy, but then we work with our physicians on any gene. So if they just read about or they read at a conference and their buddy said, hey, we just found this new gene for epilepsy, and they think that that might be what's causing yours, we'll add that to the list. The other thing is we're going to prefer a family trio, and this is what I mentioned earlier. So we can a patient, but we're going to have a clinical exome test. We're going to get back 80,000 variants per person, okay? So how do we go from 80,000 variants down to that 1 or 2 variants that are causing your symptoms? We can use a lot of techniques, but one of the best techniques we can do is looking at the parents. So if mom and dad do not have seizures and the child does, we can automatically start ruling things out or looking to see, okay, maybe this is one of those causes of seizures that where you need a DNA change from mom and dad, but there's only one here, so this isn't what's causing it, okay? So we use those parents. We don't go looking in the parents' DNA for anything else. We're just using it to interpret the child's DNA variants. Does that make sense? Okay. Cases goes down. And I'm the first. There are times where that or are going to be with us to help figure that out. We work with physicians all the time where they come to us with a case and say what kind of test is appropriate. We want to do an exome, and we'll tell them, we'll work with them to figure out, is it a genome we should quiz? So you come into your doctor. Yes, 2%. Quote, if you have, this is for any healthcare, any disease, right? Comes in with that early onset, you know about the basic biology of the disease. So people think, explain exactly what I know. So this test is actually not cases where even selecting the test is going to be personalized based on that Dr. Siliberto or your neurologist that will rule route. And there's other reasons they may not go that route first, but they are aware of it. It's a very hot topic in neurology, and it's brought up at all the conferences. So it's not like they won't have heard of it, most likely. It's just where it works, fits into the diagnostic workup, okay? So why is this all possible? And I mentioned real briefly earlier about this new technology. The new technology is called next generation sequencing. So prior to this, in 1977, a guy who by the last name is Sanger invented what was called Sanger sequencing. And this is our traditional, it's still our gold standard today. And anything we find using our new fancy machines, we will go back and confirm with, our 40-year-old technology, the Sanger technology. But what this next generation sequencing or massively parallel sequencing allows us to do is to look at all that DNA in massively parallel. So we're looking at it multiple times and we're reading through it, and we're doing it a lot faster and cheaper. We can put multiple samples together. We put actually little flags or barcodes on there, so just like, and we can scan it and figure out which DNA samples go with which person based on these barcodes. So by doing this, we can actually sequence your whole genome in a day. We can sequence it. That doesn't mean we're going to be able to interpret it in a day. And one of the jokes is you'll see about a $1,000 genome, but $1 million interpretation. And that's because there's a lot that goes into narrowing those down, the variants down to what's causing your symptoms. But there is this technology. It has made it significantly cheaper and really enabled us to do both exomes and genomes, as well as the gene panels. So what is this exome thing I've been talking about? So here are, imagine all of these gray boxes all together. cell. So bases are those letters, 3 billion of those. And so thing to change. Okay, so or to see date of known mutations, and a mutation is when we 85% of those are located in that 50 million bases. Right? Interpret, we're most likely going for and a lot faster to analyze too, because otherwise we have to go through and analyze all of about what that process. So what the exome sequence is doing, it's about 1% of your DNA. It's the part that codes for your protein, and we're looking at sequencing 20,000 genes at the same time. So rather than sequencing one gene, now we're going for all 20,000 at the same time. But we're only looking for that protein coding part of it. We're doing it because 85% of our disease-causing mutations are there, and that diagnosis rate we talked about. Although we say we're sequencing the whole exome, we actually cannot yet. The technology is still evolving. Think of it as your cell phone. So every year, the way we capture these 50 million bases and say we're only going to look at this improves. And the machine, that box on the previous slide, that improves. Those machines, anyone have a guess how long they last for and how much they cost? Any guesses?
2 months.
So $1 million is close. It's about three quarters of a million just to buy the machine. That's not anything else, not to run it. Machine sitting in the room is $750,000, and within 2 years, it's a really nice doorstop. Basically, it doesn't work. Okay, so it's just like your cell phone. Every 2 years, you're getting a new one, and so that's what's improving as well is the ability to not only capture the exome but also to sequence it. Okay. So when we do this, this is going to come up later. If you ever have an exome and it's negative, it might be that the DNA changes there. We just couldn't see it because some of those regions are just not right yet when we that it improves 1 to 2% every time we upgrade our test, which happens about every 18 months. As a result of this too, we probably, if you had the very first exome in like 2011, we wouldn't even look at that data today because we know that it's going to be so much better. We redo it. The most expensive part of this test is actually storing your data because this is data that we're talking about terabytes. So I can't open it on my computer. There's a hole actually just down the road that's analyzed and then it gets processed. Expensive. Would recommend your physician just order. If you're having that's just that little green square in the corner here of one of those boxes, okay? And those gene panels are usually focused. So the very first clinically available gene panel was out of Iowa. That was the very first use of this technology in the clinic, and it's something we're very proud of. So here, now what happens? So we've got this test. What actually happens? So your doctor orders it, and they're going to most likely do a blood draw because we get the best quality of DNA and the most DNA from your blood. The blood's going to come into lab. We're going to separate it in half. We're going to take half and run it through the test. Half, we're going to wait and use it later to confirm our results. We do make sure the DNA is okay, and we get it all prepared. This is about a week-long process here. Then it goes on the sequencing machine. So it just goes on the box. We step away for 14 days. The box just runs. This is getting faster, but it's still just the machine's going. This DNA off, we get about 100 of those letters off at a time, 100 to 150. So you have a random set of 100 letters, and you have to figure out what chromosome does it go on, what gene is it on, where does it map to. So the computers are used to start putting all the pieces back together. So think of it kind of like a Humpty Dumpty, right? We're putting all these pieces back together, figuring out what it is. And then once we do that, then we can start comparing it and looking for variants and seeing what are the changes that are unique to you. Then we start looking at the parents, and we can keep annotating this and analyzing it. When they get it down to about the top 200 variants, that's when the computer scientists who are called bioinformaticians come and find me, and they say, okay, let's start looking through this. They get really excited if it's in one of those known epilepsy genes, then they come running really fast. And they keep their office right next to mine so they can run over really quickly. And then my job as the lab and as a genetic counselor is just because she was part of this, right? We know they the best, but they're interpreting those results. So this whole process from anyone before that 12 weeks can sometimes go longer. So the cost, this is always one that comes up. Right now, the cost to do one person is $4,000. We're a send-out lab, so from the university perspective, we could be located on the moon. They're going to send a bill for $4,450. If we do a trio, the whole, to do all 3 samples is $6,100. We actually lose money on that, but it's so important to have those parent samples. We take the hit on the loss. This is not something that you're probably going to pay out of pocket. Some people will. We've worked with Patient Financial Services. If you want to pay out of pocket, there is a payment plan. They can work with you in a paid in full discount. There's specific people that we would have you talk to who are aware of this test. Usually with this test, there's genetic counseling. That'll be billed separately. Just as of this summer, that will be covered if it's a medically necessary appointment by Wellmark, which is our biggest provider here in the state. And like I said, we talk about a multidisciplinary team, and with the Iowa Institute of Human Genetics, we really take that team beyond the healthcare providers, and we have engaged Patient Financial Services. Now, if you just call up Patient Financial Services, they're going to have no idea what you're talking about, because this test is not done very commonly. So you'd want to have your doctor contact us, and then we would get you in contact with the right people who will understand and work with you. So let's say your doctor wants this. This is where the timeline. So this is Dr. Siliberto talked about patients. This is one where, again, patients comes into play because this is a new test. So it's not covered by all insurance companies. Some are covering it, some aren't, depends on the indication. But we've worked with Patient Financial Services to develop a protocol that involves Patient Financial Services, our lab, as well as your physician, to attempt to get this covered, okay? We're doing it for Medicaid and some of the commercial payers. Wellmark, to date, will not pay for this test, okay? So this process here will take usually a week or 2 because just timing and people going back and forth. We can do it in a day. But then once we submit it to your insurance, it'll take 31 business days before we'll hear, on average, before we hear a result back, whether they're going to cover it or not. So again, not the test that you're going to get an immediate response on, because even to find out if you're eligible is going to take a long time, okay? So that's if you have it. Now, findings, we mentioned this already, but this is something that patients should be aware of and ask about. So in genetics, we differentiate our findings. So primary findings are you're coming in to find the cause of your seizures, and we're going to give you results on your seizures. The secondary findings are you're coming in to find the cause of your seizures, and we're telling you your risk of heart disease, cancer, or any of those other things. Like I said, we do not do this at the Iowa Institute of Human Genetics. We can do it on a research basis, but we tend not to do this. Other labs will do this. So if you're having this test, depending on the lab, it's always a good question to ask your doctor, just so when you go back for the results, you're not surprised if they say, oh, by the way, you're also at risk for heart disease. The test limitations, we talked about this a little bit. Some parts of our DNA cannot be sequenced. Not enough is known about the cause of seizures at the time, your specific type of seizures, and then we don't know all those genes that cause seizures. It could be that the cause of your seizures is located in one of those gray boxes, and we only looked at the orange boxes, and so that could be where we just didn't have, it's not the right test, or maybe it was the green gene panel and the answer's in one of the orange boxes in the exome. So they may want to order a different test. And then the last part is that interpretation. So we need to be given enough clinical history in order to interpret those results. And that's not just like your family history, but what are your biochemical test results? What are some of the, what does your EEG look like? What are all those pieces so that we can interpret all of those variants? And so that's why your doctor's also not going to order this as the first test, but they're going to go through and do some of those other medical standard workups before they get to this test. So it's not our first test at this time. We know that's going to shift and change eventually, and it's starting to shift, but it's not going to be the first line test. So when Dr. Joshi was here, we looked and did a case study. So when you're talking to Wellmark and you're saying, okay, well, why are you not paying? Because we work with them on this. They said, well, we want to see the cost analysis. So we did a short cost analysis study. And I know you can't read this, and that's fine, but this is the laundry list of tests that often the doctors will go through and work up. And so these are 4 of Dr. Joshi's patients, and the check boxes indicate which of these tests they had, okay? And so we go through this, and we do the standard tier 1, which would be your EEGs and some of those. And anything beyond your tier 1, the cost for these 4 patients ranged anywhere from $9,000 to over $35,000 just for those tests. So all of a sudden, your $6,000 test isn't looking so bad, right? So this is the type, the insurance companies need to see more of these types of studies. And so with the Institute, we feel very strongly that like the easy part is ordering a test. I wouldn't have told you that 5 years ago before we were founded, but now I would tell you the easy part is for us to make a test. The hard part is to change insurance policies and medical practice. And so these are the types of studies that are starting to do that, and we need to be doing more and more of these in order to help get our insurance coverage to improve so that this can be an earlier. It's never going to be that first test. It's never going to come before your EEG or something, but we could knock off a lot of these other tests, okay? So also the diagnostic odyssey. So this is how long they've been working, how long it takes before the families get an answer. So for those same 4 patients, you can see the diagnostics odyssey for some of the babies was just over a year, but for some of our other kids, it was 8 years that they had been undergoing all of those tests before they got an answer. Genetic counseling, I mentioned this real briefly, and Roxanne mentioned it in my bio, so I'll just give you a brief definition of what genetic counseling is. Really, the goal is to help patients learn more about the causes of genetic conditions and how those affect them. These individuals have a master's degree typically, so my PhD is for my molecular genetics. It's not for the genetic counseling. Most will have a master's degree. That CGC means that they graduated and they took a board exam, just like your doctors take boards, the genetic counselors take boards, and it's certified genetic counselor. They're going to go over your family and medical history. They'll explain to you basic biology and genetics, and how that relates to your family. And then they may talk about testing options if that's something of interest to you. Genetic counseling does not equal genetic testing, so you can go to a genetic counselor without having to have a genetic test. They'll help you make informed choices. So they're never going to make a decision for you. And that's where it's a little different than some of your other healthcare providers. But they're going to give you the information and help you work through that decision-making process. And so they're really there to advocate for you. So if you remember anything about genetic counseling, think education and advocacy, because that's really what we're doing. And then they'll help you with resources. This is like a slide that I show patients when I'm counseling them and things to think about with genetic testing. And the counselors work through this, but this is just kind of good information to think about before you run to your doctor for a genetic test. Is there a reasonable chance that a mutation, so something that is known to cause the disease, will be identified? Not always, right? And so if you're going to do a $6,000 test, let's make sure we've got an actual chance at getting something. The big thing for insurance companies is actually this second question. And this should be the big thing for you too. Like, why are you doing the test? Are you just doing it because you're curious, but like you're not? And that's what a lot of people do with those 23andMe tests. Like, what % Neanderthal am I? I'm just kind of curious. What's my ethnicity? Not a big deal. It's a $99 test, right? But for this test, it's a lot, and it has greater implications than what % Neanderthal any of us are. So we want to make sure that what we're actually going to do with the results is going to improve the health of our patients or the medical management. What are your motivations for pursuing the testing? This comes into play a lot with patients. Sometimes patients don't want to have the test, but their family members, they might have a sister who's pregnant and saying like, hey, I really want to find out the cause, you need to have this test, and maybe the patient doesn't want it. And that's where the genetic counselor comes in and works with you on what is it that you want, okay? Who am I going to learn about? Who am I going to tell? Who am I going to learn these results from? When's the best time to have a test? Is it before, let's say it's cancer. Is it, you guys have all probably heard of breast cancer testing with Angelina Jolie. Do you want to have the testing before you have diagnosed with cancer, after? And then the one I always talk to patients about is life. Like, what is going on in your life right now? Are you, sometimes it's students, if they've got finals going on, that might not be the best time to kind of change your world upside down with how we're defining what's causing your symptoms, right? Or if you're about to get married, or you just got divorced, or you're buying a house, whatever those factors are, this stuff in general is not emergency. So it can wait and be done at the appropriate time that's best for the patient. And that's where the counselor can really come in and advocate for you if this is not something that you want at this time. We also will talk about confidentiality, informed consent. People get nervous with genetics and the cloud, those medical implications and decisions, feelings. So that's one of the things we spend a lot of time talking about, because let's say you have been on one of those diagnostic odysseys and you've been looking for the cause of your symptoms for 8+ years. All of a sudden, if I come in one day and I tell you, like, I found the cause, the way you've identified as what defines you is going to change in the matter of 30 seconds. And there's no taking that back, right? So we talk a lot about those feelings. And if you're the parents, like, that might change. And there may be survivor guilt. And maybe some of that survivor guilt is lifted when you have this and it's a de novo mutation, or if we find any of these variants that are causing seizures, we know that it's not that ice cream cone you had when you're 7 months pregnant, or that you had a drink, or any of that. We know that this is something beyond your control. So that is a really tough thing for parents to sometimes wrap their heads around. And so we talk a lot about that. Make sure our parents are communicating, because if we give back the results, obviously we want the best. My patient is actually the child, right? But the best thing for that child is to make sure our parents are on the same page. People process these results at different speed. It's very much an emotional roller coaster. And it's been so we talk a lot to prepare you. You then have 12 weeks as the test is being done, and then you can come back. And then we talk a lot about this. We don't give you a result and send you on your way, right? Because this is often the test being done at the end when we've ruled out all the other possibilities. We also talk about insurance and employment discrimination. We talk about this federal law called GINA. For those of you who remember Senator Ted Kennedy, this was his swan song. And it's a federal law that protects you from health insurance and employment discrimination, except for if you're self-employed, have a company of fewer than 15 people, or are a member of the military. You can still be discriminated against. So we talk about this. You're also not protected from life insurance discrimination, long-term care, disability insurance. So we go through all of those things with you and coach you on what kinds of things you might want to be considering before you have a genetic test. So that's a lot about the test, and it's kind of overwhelming, I know. So we're going to go through some examples. We don't have a patient here to talk about this today, but I am going to go through a couple of our fun success stories that have resulted in answers. So this will skip. So this timeline is small, and you're not going to be able to read the whole thing. And the reason you can't read the whole thing is if you ever come to visit us at the University of Iowa, outside the lab that has all those fancy boxes, this is actually a timeline on the wall. And we're about to have our lab move in the next year or two, and they're going to make it into wallpaper, actually, and have it on the wall, because it's the story of an odyssey, okay? So here we have a patient who was born in 2006, I believe. Yeah, 2006. This is one of Dr. Joshi's patients. And he had his first seizure in early 2007. So they did labs and EEGs, and then they did more labs. They're doing more tests. So everything you're seeing here is more tests they're doing. This one that looks like a little DNA double helix, that means they ordered a genetic test. Here they're ordering some more tests, genetic tests, and they start ordering. First, it's just single genes and chromosome microarrays, karyotypes, so counting the number of chromosomes, looking for big chunks of those chromosomes that are missing or duplicated. And then they start going into gene panels. So we've got 2 genes and then up to 9 genes. This fancy new technology is coming out, so we're testing it out here. And here we are in April 2013, and we still don't have an answer. But we keep doing more tests. And some of these are biopsies, too. This boy had 2 muscle biopsies, nerve biopsy and skin biopsy. Here's a little bit bigger, and what you're seeing on the bottom is in 2008, he had a brother who was born. His brother, a few months later, had his first seizure. And you can see Dr. Joshi, actually, she would alternate which test she was ordering on the child, because they're invasive and they're expensive, right? And so she would alternate between the 2 boys, because it was apparent that their seizures were they had the same type of seizure, and it was probably caused by the same underlying genetic variant. So here this is just some of our genetics consults. And in February of 2015, she had contacted us, and we drew blood for a whole exome sequencing test. 11 weeks later, in May, we gave back the diagnosis for this family. So this is the family where it was 8 years till they received a diagnosis, and then we were able to give one in 11 weeks. Our initial thought was the cost of this diagnostic odyssey was $40,000, and then we got a call from Patient Financial Services. This one was actually more. They estimate this one's more, but the financial records are only kept for 9 years, and then or 7 years, I'm sorry, and then they discard it. So a lot of the early cost stuff that the hospital would have is not available anymore. So they're estimating that these two boys, their workup was over $80,000 for the two brothers. And whereas the test, like I said, is $5,500, the hospital's going to bill you $6,100. So some people would say that the physician was doing something wrong, like why go through all this other stuff, right? But that's not actually the case. And what you're seeing on the bottom here is the history of precision medicine. So for those of you who remember the Human Genome Project, that was started, it ended in 2003. And then, so that's here on this end. And then we have our next generation sequencing invented in 2007. Exome sequencing is invented in 2008. That first clinical otoscope test was launched in 2010. And then what you're seeing here is just the various history. And what's important, the first clinical exome was launched in 2011, actually down here. And that was offered by a company called Ambry, and it was over $20,000 at the time. Now, let's say Dr. Joshi had ordered that test. It would have come back negative, and that's because the gene that was causing these boys' seizures is called PEG-A, and that gene was not described to cause seizures until 2012. So this is where, again, why it's not coming up on any of those panels, as well as, sometimes we just need time, right? We need our scientists doing that basic science research to find out the causes of of different diseases. The Institute began offering the exome in 2014, and then that Precision of Medicine initiative was launched in 2015. So up here, what I always think is that Dr. Joshi was doing the standard of care at that time, and so were your physicians, right? They've all been doing what they can. It's just now that if a child's born today, they shouldn't have to go through 8 years of testing, right? We can get that a lot shorter because of this new technology. So our first family we ended the Odyssey after 8 years. Our second family, I was hoping might be here today, but this is a really fun story where we were able to, so this one, PEG-A, this is the one I mentioned at the beginning where if mom has it, mom won't have seizures, but if she has a boy, the boy will have seizures. So that's what's called X-linked inheritance, and that's what PEG-A is. CARS deficiency is one of the ones where you need one variant from your mom in the CARS gene and one variant from your dad in the CARS gene. This was a really difficult one for us to find in the lab, but we somehow found it. We actually never should have in the lab been able to make this diagnosis based on the type of variation it was in the DNA. There's actually a really large deletion in the DNA from one parent. But we were able to find this, and this family was able to use this information for future pregnancies. When we gave back the results, they were pregnant, and they wanted to know, do we need to deliver here at UIHC, or can we deliver at our hometown hospital? Their first son had to be airlifted because he was seizing at birth, and so he had to be airlifted to UIHC. So they wanted to make those delivery plans for their second child, and were able to learn that their second child should not have seizures because they do not carry the variants in CARS. So I worked with our prenatal genetic counselor, and we were able to get them prenatal testing. And then the other one that was quite a feat for us was when we were able to get Medicaid to pay for the first exome test in the state of Iowa, and it was for epilepsy, and that family had a de novo mutation, so one of those spontaneous ones in KCNT1, which was very, very exciting. So really our mission at the Institute is to empower our physicians with tools to diagnose their patients more efficiently and effectively so that fewer families have to really endure those long diagnostic odysseys. And so that's where the Epilepsy Genetics Initiative comes into play. Some of you heard about this from Tracy, and right now this initiative is really focused on those negative cases. We have all these new genes being discovered, and so what the Epilepsy Genetics Initiative is a research study. So it's not a clinical test, and that's really important to understand. So you have to have your clinical exome test first. If that's negative, then you can go into the Epilepsy Genetics Initiative. Every so many months, so we've been in this probably close to 6 months now, and they just asked me yesterday for our first data transfer. So you come in, we give you back your results from your exome test, we can give you a consent, we can also consent you on the phone and various things like that. and then your data, the lab will transfer your data, whether it's our lab or GeneDx or any of the other labs, will transfer your data into a bigger database, which is the Epilepsy Genetics Initiative. And every so many months, like I think it's 2 or 3 times a year, they go through and they reanalyze all of the exomes to see if any of those new genes that were discovered have come up and that was actually causing your seizures. This is not diagnostic. So what happens is then they come back to the lab and the physician, and we have to get a sample from you. If it's done at our lab, we'll already have your DNA. And then we have to confirm that new variant in a clinical lab, not a research lab. So there's different quality metrics. So we have to confirm it in a clinical lab before we're allowed to talk to you and tell you we found the cause of this. So like all research studies, this does not guarantee any answer. Does not guarantee any answer in any kind of turnaround time. With research studies, there's no turnaround time typically. So you may never hear anything back from the Epilepsy Genetics Initiative, okay, if they're not finding the cause. But you also, on the flip side, is you may. It's just making sure the expectations are there when you go in that this is research, okay? And so you fill out a consent form, and then the lab takes over, and the onus is on the physician in the lab to do the rest. This is a decision tree that we have for this research study. You can't read all of it, that's fine. But basically, have you been seen here? So when we have patients, it was originally with Dr. Joshi and Dr. Siliberto. Now, if you come in, you see Dr. Siliberto. He has to fill out about a 25-page health history form on you. It's a paper one. He has to know a lot of details about your epilepsy and about you. So for you to join this study, he really needs to have seen you and done an exam. He'll do it as a second opinion usually. And then we can enroll you after that. If you aren't seen at UIHC, that's fine. There's other ways you can get involved, and there's folks at Columbia where this study is housed out of that can get you enrolled in this study instead of us, okay? So this is just one page of the decision tree, but it goes on from there. So it's something where it's not gonna be, you have to have had that clinical exome test, and then we'll work through the rest, and we'll help you through that process. Real quickly, this I added because I saw that you've kind of had this, but didn't probably realize you had this already today. So pharmacogenetics, this is just going to shift gears, but it is related to epilepsy. So that word is basically DNA variants that influence how you metabolize drugs. So all of you have been metabolizing your lunch, you're probably a little sleepy, it's warm, your stomach's full, it's churning away, metabolizing your food. You also metabolize your medications. And Dr. Siliberto was mentioning that with CBD. And so really, this was one of the big parts of the White House Precision Medicine Initiative, and the goal is to get you the right drug, the right dose the first time. Now, that's a really lofty goal, but if we can narrow down the number of drugs you have to try before you get a drug that works for you, that would be great. Like if you didn't have to go through 5 drugs, you could go through 2 drugs. So what this type of testing does, this is just showing you that basically, these are some of our most common drugs, just not epilepsy, but just in general. So we've got Cymbalta, Humira, Abilify. You've all probably heard commercials for these. The person in blue represents the number of people that this drug works in. The people in red, the number of people this drug does not work in due to genetic variations that they have, or DNA variants. So we know that 50% of the medications on the market do not work in the people who are taking them. You usually don't know it's not working unless you have another heart attack or seizure or whatever is going on. We know that your DNA variants can influence your response to medications, and that type of testing can help your healthcare provider select the best treatment for you. So this is a new type of test. We do offer this testing at the Iowa Institute of Human Genetics. Right now, we started with Plavix, so 30% of people who take Plavix for heart attack or stroke can't metabolize Plavix. So you might as well be taking a sugar pill. You're still at risk for a heart attack or stroke. So that was the first one we launched. We then developed a gene panel for pharmacogenomic genes, and we did the opioids, pain medicines, codeines, things like that. And next week, we're launching one that has more like neurology, psychology, and chemotherapeutic drugs on it. There are epilepsy drugs that are on our panel. Right now, there's not enough evidence to give you back those results because there's just not enough to clinically change your medical management. But we are talking about some research studies to look at pharmacogenomics and epilepsy and those genes. And Mike actually had some up. You probably didn't notice, but on the screen, he said there was the CYP450, and he's like, oh, don't worry about this. Those are the ones I worry about, because those are on these drugs. So I get excited when I see CYP450, because those are things that are on our panel. And so those are, we think that there's probably some role with CBD metabolism as well. Right now, it's not known. There is zero known about this. So it's not like you're going to hear something in the next 2 months, but we're working on designing studies where we can start getting at some of these answers for not only CBD, but other epilepsy drugs as well. So, sorry, I probably, thank you. And if you have any questions, probably take one, or you can come find me afterwards. Whatever you want.
So how about, thank you, Dr. Freeman. So we're going to break down the room for our connection groups because we're running a little long. Would you be able to visit with families out in the lobby? We have cookies out there. They're just going to put the dividers down in the room. And so as soon as they get the dividers down, this middle section, we're going to have connection groups because from our evaluations in the past years, people want to interact with other people with epilepsy on a similar journey. So this middle section will be for parents of children with epilepsy. This section over here will be for adults with epilepsy. And then this section over here will be for professionals, direct support staff, and we're going to talk about those seizure trainings and supports that we have for professionals that work with individuals with epilepsy. So we hope you'll stick around and be a part of our connection group. And don't forget to continue filling out your evaluations. You may want to take your items with you because they are going to tear down some of the tables, and then we'll come right back in as soon as they set up the room. Thank you very much.
I did have asked you before a time, and like a clock, and then I should have taken my watch. That's right.
That was excellent. That's excellent.
Hopefully next year we can have like the pharmaco study, like preliminary results.
Yeah, I know. That would be awesome. So, I have a question.
Yeah.
So,